Welcome back, everyone. We will be starting our second session of the day today. It's titled Complex Hemodynamics, another, I would say, area where interventional and heart failure intersects. I have already introduced myself. For those of you who've just joined in, my name is Manreet. I'm a heart failure cardiologist at Allegheny General Hospital in Pittsburgh, Pennsylvania. I'll ask the panel to introduce themselves, and then we'll have our first speaker set us on.
Navin Kapur from Tufts Medical Center.
Miguel Alvarez from Lenox Hill Hospital, New York.
Jim Udelson from Tufts Medical Center.
Srihari Naidu from Westchester Medical Center.
Hi, and Steve Sue from Johns Hopkins.
I'm Bill Cornwell from University of Colorado here in Denver.
Bill, you want to get started? So we'll just start with our first talk. So this is Bill Cornwell, who's coming to us from University of Colorado. So probably had the easiest commute of many of the people who are joining us today. But Bill's going to be talking to us about advanced hemodynamics in the Cath lab. This is a really important topic that's becoming even more front and center for Cath labs and interventionalists around the world. So thanks, Bill, for joining us.
Yeah, thank you very much.
And just to let people know that if you have a question in the audience, please raise your hand. Dr. Kataria has kindly agreed to basically bring you a mic, so please feel free to ask questions during the discussion period. Thanks, Bill.
Yeah, thank you. Thank you very much for the opportunity to present today. This really is a wide topic, and in 10 minutes, I'll do my best to do justice to the topic at hand. As a general outline for the things that we'll quickly review today, when I think about advanced hemodynamics and where that fits in the Cath lab, there are a few areas that I would like to focus on and emphasize. One is the care of patients in cardiogenic shock. The second is management of advanced therapies, and that pertains to everybody who's being considered for it, managing complications during and afterward that come up, and also just the general maintenance and well-being of our patients who have benefited from these kinds of therapies. Thirdly is evaluation of symptoms that develop among patients with cardiovascular and pulmonary disease. And then finally, personalization of care. We'll talk about that just for a minute or two and how advanced hemodynamics at the bedside and in the Cath lab can really improve our ability to provide care. These data, I'm probably speaking to somewhat of a biased audience, but I don't want to take these kind of things for granted. This was a very nice study demonstrating the utility of hemodynamics in the management of patients with cardiogenic shock. Very large observational analysis, well over 200,000 patients who were followed to determine whether or not hemodynamics improved the ability to provide care when patients are suffering from cardiogenic shock. A couple key findings that I want to highlight here. First of all, you can see that a small minority of patients in this very large database were treated with a right heart catheter and hemodynamics, about 10% of individuals. And it is notable that individuals treated with right heart catheterization and hemodynamically derived medical therapy were much sicker. They had more comorbidities. But if you look at the data from this study, we look specifically at things like death, stroke, hemodialysis, readmission rates, and need for transplant and LVAD. You can see that right heart catheters were associated with a reduction in these outcomes, and these persisted with propensity-matched analyses when they matched people based on their comorbidities. This is an interesting finding here, that right heart catheter was associated with an increased risk of transplant or LVADs, and I don't want you to stop and scratch your head and say that means that heart catheters are dangerous. Quite the opposite. The implication here is that right heart catheters allow us to better identify patients who might be candidates for these types of therapies and guide our overall decision-making process. So I would say that hemodynamics should be incorporated early in the management of patients admitted with cardiogenic shock to guide clinical management. Again, if you look at this, less than 10% of patients with cardiogenic shock were managed with a right heart catheter, and I would say that this needs to be a tool that is routinely incorporated into our medical management and clinical decision-making to improve overall level of care. Now, I want to move beyond just traditional hemodynamics, and I've put up here challenging traditional paradigms. Well, we can think about different ways we can look at right and left heart function. We have non-invasive techniques like echo. We have our invasive assessments using a traditional Swan-Ganz catheter, which most of us are familiar with. And then we have these fun toys, which several people in the room, I see a lot of familiar faces and people on the panel up here, have become accustomed to these conductance catheters, which provide real-time pressure volume loops. This is from one of the participants in some of our studies that we've done. And the nice thing about these is that they allow you to have a much greater level of granularity when you look at ventricular function. We can look at things like contractility, lusitropy, myocardial energetics, and what I would argue is perhaps the most important of all of them, ventricular arterial coupling. Simply by using these fun toys, these conductance catheters that generate real-time pressure volume loops. I want to give you a fun example here of how these things can help us analyze and understand ventricular function. Let's talk for a second about how the right ventricle responds to hypoxia. We're all here in Colorado. This is my home state. Hopefully some of you will go up to the mountains to enjoy some time before you go back home. But what I want you to ask yourself is, what happens to your heart when you go to exercise in the mountains? Well, this was looked at almost 3 decades ago in a study called Operation Everest 2, and the goal was to characterize cardiac function on the summit of Mount Everest. And you're wondering right now, we're here talking about heart failure. What does this have to do with anything? But just bear with me for a second and I'll make the point. What they did was they performed invasive hypoxic CPET tests to better understand how the left and right heart function. And regarding the right heart, they concluded that right atrial pressure is normal while exercising on top of Mount Everest. So the implication here is that the RV is unaffected by an increase in afterload. That has relevance to the ICU. The increase in afterload resulting from hypoxia and RV function is normal under these types of hypoxic scenarios. My question is that I put out for the group, how might pressure volume analysis further clarify ventricular performance above and beyond what we could learn from an echo or a traditional Swan-Ganz catheter, and what types of implications could we make at the bedside? Our group, we tried to better understand this a couple years ago. This is an example of an invasive hypoxic CPET where the individual is breathing hypoxic gas from Douglas bags, simulating an altitude well over 14,000 feet. And just painting with broad strokes here, again, when we think about pressure volume analysis, we can look at things like contractility, lusitropy, myocardial energetics. And just as a reminder, I told you the original findings from that Operation Everest 2 trial were that the right atrial pressure is normal, so RV function is unaffected by hypoxia. And one of the things that we learned from this type of advanced hemodynamics is that it's not just that the right ventricle is normal, it actually significantly augments contractility, lusitropy is significantly increased, and myocardial energetics when you exercise or when the body is stressed, when metabolic demand increases in response to a hypoxic scenario. So I would argue that assessments of ventricular performance are more comprehensive and thorough with incorporation of this, what I would say are these next generation types of invasive hemodynamic assessments. One of the other examples that I always like to point to, I love this study, came out in HFrEF almost 6, 7, 8 years ago now from the German group. And this study very nicely demonstrated that HFpEF is a biventricular phenomenon. What are we looking at here? In the graph, we're looking at the diastolic limb of a pressure volume curve. That tells us a lot about lusitropy or diastolic performance. And what they did here in red, they had patients with HFpEF do a simple hand grip type of exercise. So you just sit there and grip your hand and ask yourself, what's happening to your heart when that happens? And they did it in control populations in blue. And what you can see, looking at this RV EDP curve, is that for the HFpEF patients, when they go to exercise, you see this upward shift in the EDP curve, but you don't see that in the control population. And what that tells you, like I said, I already gave you the answer, HFpEF is a biventricular phenomenon. It's not just the left side of the heart that is affected, the right side of the heart is affected as well. And if we didn't have this type of advanced hemodynamics, we would never be able to appreciate the impact that HFpEF has on the global function of the heart. We tend to be naive and think about the left heart. I would argue the right side of the heart is just as important when we think about HFpEF. Moving on, what have we learned in other populations? What types of things can we say? Well, These are example loops from multiple patient populations that we've studied in my lab using these fun devices. Healthy controls, purely healthy individuals, HFpEF, HFrEF, and HFrEF supported by LVADs. And I would argue that you can make some implications about differences in ventricular performance in these, but we need to be asking the question, humans were not designed to live flat on a bed. They get up, they walk around, and if you really want to understand how the ventricles, left and right, perform in our patients with different types of disease, we need to be thinking about doing invasive hemodynamics in the Cath lab. And when you do that, what I've plotted up here on top of the resting loops are exercise PV loops at submaximal levels of effort and peak exercise. And again, I'm just painting with broad strokes here in the interest of time. One of the things we can see, if you remember nothing else about a pressure volume loop, we all remember from medical school that the wider the loop, the wider the stroke volume and cardiac output goes up. Well, a healthy heart, there's substantial contractile reserve in the right ventricle. Patients with HFpEF don't really suffer from impairments in contractile reserve. Their problem is stiffness, where we see an up and leftward shift in the loops. HFrEF, we see that there's minimal contractile reserve, and then we have similar physiology demonstrated in patients with LVADs. And one of the things I like to point out here, if you look at the loops on the right, in the studies that we've done on patients with HFrEF and LVADs, these are individuals that under supine resting conditions were concluded to have normal right ventricular function. But what you can see here is that when these individuals get up and begin to exercise, we have evidence of RV dysfunction that is quickly unmasked simply with submaximal levels of effort that simulate real-world activities of daily living. Again, emphasizing this concept of the need to study patients by doing invasive hemodynamics in the Cath lab. This is one final example of this, which I always like to point out. This is from a paper in JCF that came out last year. 67-year-old man with an ejection fraction of 23%, who we had in our lab undergo hemodynamic assessment during rest, which you see on the left, 2 levels of submaximal exercise, and then peak effort. And then we're looking at right atrial pressure, PA pressure, wedge, and blood pressure. What you can see, and I want to point your attention to the submaximal levels of exercise here, is that during just easy effort, we see marked increases in PA pressures. We see wedge pressures that are in the mid-30 range, and we see a blunted blood pressure response. And you would never understand the severity of the hemodynamic abnormalities that our patients with heart failure suffer from if all you did was analyze them by a supine resting hemodynamic assessment. So I would argue that supine resting hemodynamics are insufficient for characterizing the extent of hemodynamic abnormalities that our patients suffer from when they're in an upright ambulatory position. And then lastly, like I said, personalization of medicine. These are 3 examples of how pressure volume analysis, so advanced hemodynamics in the Cath lab, can be used and incorporated into patient care to optimize pacing strategies for patients with heart failure. In 10 minutes, we can't get into the details here, but I've underlined the concluding sentence from one of these papers, that pressure volume guided hemodynamic optimization in CRT results in approximately 1/3 of stroke volume improvement on top of conventional CRT. So these are nice examples, again, of how advanced hemodynamics incorporated into bedside management of our patients can improve ventricular performance and help our patients improve their quality of lives and survival. So summarizing thoughts just to conclude, when caring for patients with cardiogenic shock, hemodynamics should be incorporated and help guide management and clinical decision making. We need to be paying close attention to these, reassessing our patients to help guide these medical decisions, helping us to understand whether or not they are candidates for advanced therapies, if they need to be transferred for higher levels of care, or do we need to be having end-of-life discussions or discussions on palliation, depending on the hemodynamic response. And again, like I said, I'm probably talking to a biased audience here at a conference on invasive hemodynamics, but I would strongly argue, and I think the data would support, that invasive hemodynamics are grossly underutilized and underappreciated, but something that we really need to be incorporating into routine management of our shock patients. PV analysis, as we discussed, provides a more comprehensive assessment of ventricular performance beyond traditional measures. Medical care can be personalized by considering these hemodynamic responses of specific individuals. And mechanistic studies incorporating these types of advanced hemodynamics may provide a platform for advancements in overall patient care. With that, I'll stop. Thank you again to the moderators. It's a lot of fun to be here. And take any questions.
So Bill, that was a great talk, and thanks for joining us. I'll just open as people are collecting their thoughts, and again, Rachna's in the audience. If you raise your hand, I'll try to bring you a mic. Bill, maybe you can just tell us, in the idea of just from a technical perspective, what are the barriers to invasive hemodynamics in the cath lab, and especially around conductance catheters, and maybe tell us a little bit about your technical practice in terms of volume calibration, et cetera. But I think for a general audience, one of the biggest debates has been whether or not conductance catheters will ever become a standard of care for invasive hemodynamics.
Yeah, that's a great question. This is a subject that I have had many conversations with the company that makes these. Cardiologists want an answer now. We can put a Swan-Ganz catheter in and know immediately what the hemodynamic pressures are, and we also know what the numbers mean. If I were to say that somebody's preload recruitable stroke work was 7, there's probably 2% of people in America that would have any idea what that even means. So number one, there needs to become a greater familiarity with these things so that we understand what these numbers actually mean. And then number two, we need to get better at, or the company needs to get better, I would argue, and anybody who's used these would agree with what I'm about to say, at providing the answers that we need. I generally will spend anywhere from 8 to 10 hours analyzing PV loops on a single patient, and as cardiologists, we just don't have time for that in the clinical realm. We need an answer now. To be quite honest, I have a love-hate relationship with these things. I love them because they give a wealth of information. I very much dislike them because they are very cumbersome. And the second thing that I would argue is the success rate is not 100%. Anybody can advance a PA catheter into a wedge position. These things are not the easiest. They're very stiff, they're cumbersome. You need a stiff wire to advance them into the ventricle, and when you have a sick patient with a sick heart, that might not always go well, and you might not always be successful. And that also is important to consider when these things cost $1,500 a catheter. So as far as, I think the second question was on volume calibration. This is, I think it was, I don't remember who made this comment once, that when calibrating catheters, it's not the catheter that needs calibrated, it's your expectations that need to be calibrated appropriately. And I think that's a great way to summarize my experience with these things. There are 3 ways to calibrate them. You can use it, you can get a volume assessment by MRI, you can get a volume assessment by echo, or you can use hypertonic saline. There are pros and cons with all of these. I have traditionally used hypertonic saline because it's immediate. The data generally in animal studies are good supporting hypertonic saline. That involves basically injection of about 8 to 10 cc's of 5% saline. I mean, we've done this to multiple populations. It's very well tolerated. I've not had anybody who's had any problems receiving that level of saline. But I do like it because it's immediate. There's no lag time. Hemodynamics may change if there's a day or 2 or a week between the time that you do the catheter and when you get your echo or your MRI. So pros and cons to all of these things. They're very cumbersome devices. I do like them because of the information that they provide, but they are by no means perfect, and we have a long way to go before they ever hit mainstream at the level of a Swan-Ganz catheter. Sorry, long-winded answer, but important topic.
Comprehensive.
When we think about these.
That was an excellent talk, and actually so great to finally hear you speak in person. I think this brings me back to some of the discussions from the first session about how we can enrich heart failure fellowship with so much that it has to offer. But my question to you is, if the adoption of resting invasive hemodynamics is low, exercise is probably lower, does some of that have to do with how that translates into what you can potentially do for the patient? And then what are some of, you gave an example of like CRT, but what are some other things that you find yourself doing in terms of treatment based on the data?
I would argue that a supine resting assessment does limit what you can do for patients because, and I think everybody in the room would agree, we very frequently have patients come in who have symptoms with routine activities of daily living and their echo is not helpful and their supine resting hemodynamic assessment gives you very limited insight. I don't know how many times I've done upright invasive hemodynamics on somebody who's got a resting wedge of around 12 to 15, and within 3 minutes of submaximal exercise, their wedge is in the upper 20s or low 30s. And if you didn't do that, you wouldn't have an idea as to what the problem is with the patient. So I know it's burdensome, it's cumbersome, it's not easy, but if we want to help our patients, then sometimes you've got to do what you got to do, and that means an upright invasive hemodynamic assessment.
Arvind, last question.
Well, thank you for simplifying a lot of this complex phenomena. I think I do agree with you that volume calibration should be saline, just because you're going through all this complicated analysis and using an MRI, which was 2 days ago, doesn't make sense. My question to you, which you alluded, because I share the pain and the enthusiasm that happens in the Cath lab when we do these cases, is anybody working on a simpler clinical applications of AI-based analysis? And two, is it simple, we can slap on some sensors to the impeller that's already in the LV to guide us in coming up, and how does noise factor into the particular
Yeah, the first question regarding AI, I don't know the answer to that, but I would argue, as with everything else, the direction AI is going, that's probably inevitable, and it will probably, certainly will help. The second question regarding noise, I have been surprised by these things that, we put them in people and we exercise them and we get good loops. I've been very surprised at the reliability of them once they get into place. It can take a while. I've spent a good 45 to 60 minutes sometimes getting it into a position where I like it, but once it's there, it tends to stay there and gives good data with minimal external noise.
Thank you so much, Bill. Always a pleasure to hear you speak.
Thank you, guys.
So I think we have on our panel one of the other 2% people you mentioned would understand what the heck you're talking about. Stephen, for the next talk.
It's on. Okay, great. Oh, sorry. Thank you. Oh, that's backwards. All right, thank you to Navin and the CVI organizers for the opportunity and honor to speak today. We'll talk about a clinical case. I guess my disclosures are that I am heart failure trained, and so I have a sore lack of pictures and Cath images here at this interventional conference, which I will fix if I ever have the opportunity to come back again. But here we are with a clinical case. I just write notes all day, really. Now I'm into the Cath lab a little bit. So we have a clinical case of a 67-year-old woman with chemotherapy-induced dilated cardiomyopathy. She lands on the medicine floor with acute decompensated heart failure. The story will be very familiar to many, but her heart rate is notable for being a little tachycardic and sinus. Blood pressure a little low, 107/68. On examination, her JVP is elevated, and labs show a little bit of a renal dysfunction, a little bit of a T-billy. The lactate is kind of borderline detectable. And her echo shows a dilated LV, EF 10 to 15%. RVSP notably is 70 millimeters. But with that, her RV seems okay, at least. RV is only mildly dilated with moderate hypokinesis. The TAPSE is 18. There's at least moderate TR and some septal flattening and diastole. So the team, so let me pause there for a second. This is a great study by, we have two of our esteemed moderators here who are co-authors on this paper. So in this study, using great data from multiple cardiogenic shock registries, 3 different phenotypes of cardiogenic shock were identified. And I think it's helpful to think about this when we see patients, because bucketing them into these different categories helps us prognosticate exactly how sick your patient is in front of you. So here we basically have kind of flavor 1 versus flavor 2 versus flavor 3 of heart failure. In flavor 1, it's primarily heart isolated. In groups 2 and 3, we basically have heart failure that's essentially metastasizing to other organs. In group 2, lungs and kidneys, and then in group 3s to the whole body, including the liver. And in this study, basically using kind of machine learning algorithms, they came up with 3 different groups of cardiogenic shock patients, and they essentially sort out based on hemodynamic and lab values into these 3 groups. So if I take you through group 1 for a second, that's the red line, you can see that these patients generally have pretty good cardiac power output, cardiac power index, they have good systemic blood pressures, they have good PAPIs, so they have good ventricular function, they have good GFR, and they're basically sick heart patients, but the disease is still kind of isolated to the heart, and the heart is not half bad. If we advance their heart failure a little bit further, now we get into this group 2 group, and we see these patients a lot. They have kind of a combination of lung and renal dysfunction. You see now that if we focus on the green, that their that their pulmonary pressures are starting to go up. If you look at the lower left corner of the hemodynamic variables, their BUN is going up, their creatinine is dropping down. Basically this lung renal picture. And then the final picture, which is the picture of our patient right now, these are patients who are now starting to have systemic heart failure with signs that the RV is starting to fail, the liver just upstream of the RV is starting to go kaput, and then there's also kind of hemometabolic shock going on with abnormalities in the CBC. And so you see in the blue, RAP is up, right atrial pressure, heart rate, lactate, a lot of your LFTs are abnormal, and then now a lot of your CBC are abnormal. So I think of these three patterns because it helps you to bucket these patients. And if you know what bucket your patient's falling into, it can tell you exactly how sick they're going to be this hospitalization. No matter which registry this group looked at, whether it's the cardiogenic shock working group or two other great registries, like you could see, as you progress from 1, 2 to 3, boom, the mortality starts to escalate significantly during that same hospitalization. So when we go back to our patient, we're really working with a class 3 type of heart failure patient who's sick on all fronts. And this is borne out in her first 24 hours, which is always very critical to these patients. She's basically sitting on the floor in shock, as we know. So unfortunately, her home medications are just continued. She's giving boatloads of furosemide and only pees out 1.4 liters. And not surprisingly, vitals are about the same. BUN and creatinine start to escalate. T-billy's going up, lactate's going up. Then we get called. And so we recommend a right heart catheterization, and here are her numbers. They are not pretty. RA pressure 25, wedge 30. Her index is 1.25 with giving her a PVR 6. That's her blood pressure and heart rate, same as about the floor. But you could see that she's very tachycardic and doing a lot of peripheral oxygen extraction to make up for the fact that her stroke volume is pretty abysmal. And then more advanced calculations down below. Her PAPI is about 1.1. Her cardiac power output is 0.47. And so an intervention was done, and you can see her numbers afterwards. And I wanted to poll the room here and see what you think was done. Here's A, B, C, D, obviously escalating in terms of aggressiveness. But let's say just by show of hands, who would do one, option A in this scenario? Option, okay. So some people would do A, and we could talk about why we would choose different things during our discussion. What about B? Oh, okay. C? What about D? There's some algorithms that I picked a case that had really, at least on the surface, bad biventricular numbers with low PAPI and cardiac power output. Some of the kind of algorithms being written nowadays might shunt you towards ECMO in that situation. But the panel, I think, was right. Like, most of you guys picked A as the first shot. This patient's on the floor, hasn't really seen much of anything. So, she deserves a shot at nitrite and milrinone. And lo and behold, that's exactly what she got. And I think this scenario illustrates this concept very well. I think she was so volume overloaded on admission that she was showing signs of pericardial restraint. And so we think of the hemodynamic circuit as kind of this single file system, goes from body, RV, lungs, LV, back out to the body. But in addition to being a circuit in series, the two ventricles are operating in parallel, and they're confined by this pericardial space. And there are many situations in heart failure where the pericardium can start to impact what the RV and LV do relative to one another. And I think this is a great case of that. So in her situation, we can see that on admission, the RV was under a lot of stress. I mentioned that septal flattening in diastole, even though some of the RV parameters look not half bad, with a little bit of, so in these situations, the LV is a fixed space. You can only add so much water to it. The pressure will not go up infinitely. So once you fill the LV up in a patient with a failing LV, next place you fill up fluid is the lungs. But again, the lungs are also a fixed space. You can only fill them up so much. After that, you just start filling up the body and the CVP and the RV till the cows come home. And that's kind of where all the water starts to fill up in that body as that patient persists in heart failure. So you can have situations like this where they are so volume overloaded that the body systemic, the CVP and the RV are just completely chock full. And you have a patient whose RV is now so full that it's pushing back against the LV. This becomes important because when that happens, you can really start compressing the LV and limiting the amount of filling you have in your LV and thus systemic blood flow. So in this case, we can use RA pressure as a surrogate for pericardial pressure. And in her case, her RA pressure was quite high. But when cardiac and pulmonary filling get to the point where you start pressurizing the pericardial space, you can really start to impede RV filling, which then biventricular interaction starts to squish on the LV, as you could see up here with the pictures and the numbers that we're showing here. And this is what happens in real life. So if we focus on the normal in the middle, those are our LV and RV diastolic filling pressures. If I focus your attention on the left, with acute RV distension, look what happens to the LV end diastolic filling pressure curve. We actually get a left shift on the left side because the RV is full. And that's because the RV is so full that it's starting to push against the LV, and the LV basically now is getting more pressurized, but it is not equaling more volume. Some of that pressure in the LV is directly because the RV is pushing against it, and the LV is now underfilled at any given pressure. And so this is a really important concept that leads to hypotension in our patients. It can lead to reduced forward flow from the LV. This happens in heart failure, it happens in PH and RV failure, it happens in all sorts of situations. Bill brought up a nice scenario of how in HFrEF we can get leftward and upward shift of the right ventricle, and that kind of probably to some extent happens in the HFrEF patient when we distend the LV. These ventricular interactions are bidirectional. So we get a little bit of good result with the milrinone and nipride in our patient, and she undergoes ongoing PA catheter-guided guidance and diuresis. But a funny thing starts to happen over the next few days. We essentially plateau. CVP gets stuck at about 10, wedge gets stuck in the mid-20s, index gets stuck at 2. Every single day, the plan is the same. Diurese, diurese, let's take out this volume. She pees like 3 to 4 liters a day, but someone notices like, where's the weight coming from? When there's this discrepancy between the weights and the urine outputs, everyone starts invoking like, are they drinking water from the bathroom? Like, why are we not having conservation of mass? Anyways, and then the JVP remains elevated. She actually doesn't have a lot of edema anymore. Whatever edema she had on admission is gone at this point, but the JVP is just still rocking at the earlobe. And we hit a plateau. The creatinine kind of plateaus back to its admission of 1.4, T-Billy's 1.3. This is a lady, though, mind you, with no diabetes, no hypertension, no intrinsic renal dysfunction. So as she's undergoing her advanced therapy evaluation, we start looking at the scenario and we start thinking about the next major issue with the RV, which is that truthfully, when it comes to the RV and HFrEF, all of our therapies really need to be directed at completely optimizing the LV and the lungs to make sure that the RV works as well as it does. And in this situation, I would argue that even though the index is 2, that's pretty borderline, our wedge is still high, we have not completely offloaded this LV. So what are some next steps that we can think about in this patient with all that in mind? Do you think she's good enough to send to LVAD now? Do we list her for transplant like this? Do we consider escalating her mechanical support? By show of hands, how many would do A? Or B? Seems like she needs a little more work. So yes, so we did in fact escalate to temporary MCS. And I think, when I think about the RV and HFrEF, I think about many situations where pressure does not necessarily equal volume. We use right heart cath and we use pressure measurements as a surrogate for volume, but as hemodynamicists, we really need to cross-check our numbers with the patient and with our volume assessment of the patient and where that volume is. So, for anyone who's kind of familiar with the DC area, the beltway is just horrible. This does not show up well, but like at any given day, like you'll see just this complete pileup of redness, like right around like 10 o'clock, like between the bridge going from Virginia back into Maryland. And I think about this a lot because essentially, this is what can happen in our patients. When we think about diuresing people, sometimes we use this very transactional idea. Oh, maybe it's like a bank account. If I could withdraw 4 liters per day from my bank account, in 7 days, I should be down 28 liters. Unfortunately, the body doesn't work like the bank account. I wish my bank account were such that I could just withdraw $400 per week, and it would. So in the human body, what really happens, and we see this, is the human body works much more it finds its equilibrium. In that way, it's much more like the thermostat in the room or our weight. We can do all sorts of stuff to the human body, but unless we fundamentally change the situation of the heart and lungs, you'll find that with ongoing diuresis, your pressures may not change at all. And this happens all the time, and yet we put it in our plans every day, diurese, diurese, diurese. It's no wonder, Navin, you brought up this great point, unless you diurese for days, you might not see a lot of volume removal. Volume removal in isolation doesn't always work, because sometimes the fundamental problem is not volume, it's that the flow is so bad at some particular spot in the circulation that pressure will always be high in that area, no matter what you do to volume. And in those situations, you need to fundamentally fix the pressure buildup. You can't just keep pulling off volume. So in these situations, you can't just keep diuresing. You need to augment flow. You need to fix that underlying problem, whether it was an acute MI or PE or valvular insult, or some severely sick LV like we have in this situation. And you need to target the underlying pathophysiology. So in our next steps, we agree all that she's not perfusing well out of that LV. We've kind of hit a roadblock. We stick an Impella in. Now we get better cardiac output and flow. Now you really start to see that CVP come back down. Unfortunately, due to some concern for lingering malignancy, she was not a heart transplant candidate, but she went on and did very well with her DTL VAD. So treating the RV and HFrEF, I think my messages would be, when we see concomitant RV failure, elevations in RA pressure, tachycardia, hemometabolic picture, these are the sickest people that we have in HFrEF. You really want to optimize treatment of the LV and the lungs, and make sure that you don't stall out on those treatments. And then be cognizant of pericardial restraint when you're first assessing the RV, and make sure you don't judge it too harshly, up front. Thank you.
Great, Steve. That was a phenomenal talk, really thoughtful, and I'm glad we didn't go further on your personal finances. Actually, Manreet's talk, I think, dovetails really nicely with yours, so I'm going to have her present, and then we'll open up for questions on the RV side.
Perfect. Thank you.
So next up is Manreet, talking about, can we get her slides up, please? Talking about biventricular effects of LV unloading in heart failure with reduced EF.
So I chose 2 cases, one to highlight how much we think we understand the RV, and the second one to highlight how much we don't understand the RV in terms of LV unloading in HFrEF. So, where do I point this, I guess? Okay. So here's my first patient, David. This is from a few years ago. This is a gentleman with no known past medical history, has URI symptoms, subsequently develops progressive shortness of breath, orthopnea, and presents to an outside hospital with hypotension, rapid AFib, but sitting up, talking to us, not appearing obtunded, cold at that time. He gets started on the customary cardizem drip. When that did not push him into shock, he gets low pressor, and then subsequently gets started on levofed and sent to our hospital. This is his presenting echocardiogram, biventricular dysfunction, global, but a non-dilated LV with no significant other valvular abnormalities, etc. So even though he was sitting there talking, and again, this is a previously healthy gentleman, which is probably the only reason why he didn't look as sick as his numbers did. But as you can see, very high lactates, ALT, AST already on the climb, the cardiometabolic syndrome that Stephen was alluding to at this time. So we took out our friendly CSWG shock app to try and understand which sky stage this gentleman falls into. And it tells us that this is a patient who, even though, again, sitting there talking to us, is truly SCAI stage D based on the information that was just provided on the lactate. And again, I wanted to emphasize here, we don't really need SWAN hemodynamics just to initially risk stratify these patients. But since we didn't want to, not do a SWAN, so that's what we did. And this confirmed significantly elevated biventricular filling pressures, a CVP of nearly 20, veg that's elevated, cardiac index that's low, sort of confirming that even though this patient did not look as critically ill, this is kind of an impending doom scenario. So at this point, we reminded ourselves that, again, even though this patient is coming in with primary LV shock, LV failure, what we often underestimate is the role of BiV congestion in these patients, RV dysfunction. And this was our first cardiogenic shock working group paper, which emphasized this point that nearly 50% of patients with LV shock actually present with a BiV congestion profile. And this is associated with higher rates of mortality in this patient population because it's often underestimated and underscored, unfortunately. So we decided to proceed with an Impella placement in this particular patient. Of course, there was a concern, is the RV too sick for it? Because we are going to mechanically intubate this patient, give him some sedation, but we felt we were gonna get away with it, and this is the of course, these are not his PV loops, but just reflective of what an Impella unloading would do. Increase your aortic pressure, of course, decrease your preload, decrease your LV filling pressure, induce LV-AO coupling, and result in this particular patient, significant hemodynamic improvement within the first 24 hours with almost near normalization of filling pressures, both on left and right side within 48 hours with massive diuresis. This did not translate quickly into LVEF recovery because we could not really cardiovert him till he was adequately decongested. We tried a couple times and failed, but then just waited patiently till we felt he was truly unloaded, cardioverted him again, were able to add GDMT, and then wean off his Impella 5.5, and he went on to live happily ever after. Now, contrast case, very similar to what Stephen had presented, only this patient was where we thought we understood the RV. We sort of followed the steps of our algorithm, and yet did not do well by this patient. So a slightly older gentleman, this gentleman has end-stage known chronic systolic heart failure, known chronic RV dysfunction, is in and out of the hospital with severely dilated biventricular dysfunction. About a year ago, his right heart cath confirmed that he has BiV dysfunction with a borderline cardiac index. We kept trying GDMT, this, that, and such, but eventually, with his worsening renal function, decided to evaluate him for advanced options. We brought him in for an elective LVAD with the goal to optimize him, but prior to that, he was not felt to be a candidate for transplantation because of his pulmonary hypertension and other comorbidities. And as you can see, again, confirming high CVP, high veg, low cardiac index, and a PVR that was again prohibitive for transplant listing, and an echo that again continued to show severe BiV dysfunction in this scenario. So just to remind ourselves, chronically left untreated, elevated left-sided filling pressures shown here as high right atrial pressure, high left atrial pressure, initially will be, isolated post-capillary pulmonary hypertension, which we all see in patients with left heart disease. But if you leave the LV unloaded chronically, and yes, this gentleman was getting diuresed in and out of the hospital, but probably never had her normal pulmonary capillary wedge pressure for years, and that translated him into probably not being decongested on either ventricular side for years. This led to reactive pulmonary hypertension, eventual remodeling of the pulmonary vasculature in this case scenario, and eventually led to combined pre- and post-capillary pulmonary hypertension, which again had developed over years, unlike our first patient who was kind of quick acute myocarditis scenario where the RV was quick to unmodel. So we started off with the nipride milrinone approach. I skipped that in the interest of time. And even though we saw some initial diuresis, we plateaued pretty quickly and decided to escalate him to 5.5 to see, can we stress test the RV and get the results we want to see? What would happen if we were to put a VAD in him? And yes, after about 9-10 liters of diuretics, our hemodynamics looked very reassuring. But this is, mind you, on 0.5 milrinone, high-dose Biomex drip, and P8 of Impella support at this time with some off and on nitride. His renal function improved, and we declared him worthy of an LVAD candidate. We did not think he would need an RV support, but we told ourselves we'll have a low threshold in case things don't go well. So we mentally prepared himself and ourselves for a BiVAD approach coming out of the OR. And that is exactly what happened. Between induction, fluid shifts, sedation, his CVP shot up within minutes of him being induced for anesthesia. He gets an LVAD, but unfortunately we can't spin the LVAD at the speed we would like. We can't unload the LV because the RV starts to fail more and more so. So he comes out of the OR with the RVAD, so BiVAD configuration, which is what we were sort of worried about, but thought we had gathered enough information to prevent this complication. Unfortunately, we were not able to successfully wean his RVAD. We took it out once. We had to replace it. Incessant VT ensued. His RV just completely gave out, even though his LV was adequately unloaded at this time. And he ended up on dialysis. Multiple complications ensued. And after nearly a month of this, that, and all sorts of, with not having exit strategy of a transplant as an option, we lost Mike after about a month of protracted hospital stay. So what happened to his RV, even though we thought we had unloaded it for 3 days and that should have been enough, what we truly underestimated is what the degree of chronic LV chronically unloaded LV does to an RV. And even though, yes, his hemodynamics seemed to have responded short term, we just did not give him enough time. Maybe we should have left him on inotropes longer. Maybe we should have left him, I don't know if another 4 or 5 days of LV unloading would have done the trick. But what we did then was insult the RV again by putting him through mechanical ventilation, sedation, fluid shifts, and then the additional 5 liters of flow coming from the LV side. And that was just probably one thing too many for this RV to handle, with additional preload, additional afterload, sedation, intubation, et cetera, et cetera. So again, how do we differentiate Mike from David? So David, again, had a non-dilated LV, was quick to respond. His LV hadn't seen congestion. His RV was quick to respond as well. And his filling pressures normalized within 24 hours. Whereas with Mike, yes, his filling pressures improved, but we truly underestimated how sick his RV was. And then add to it insult to injury, it did what we sort of kind of were worried about, but still thought we could get away with it. And of course, to try and understand this beyond just hemodynamics, as Stephen and Bill were mentioning, we had our echo, we had our RV, we thought we understood it. And of course, we did not do PV loop hemodynamics for him. But on the left, you see what happened to David's RV, probably with the Impella, is all the things we were hoping it would do: decrease the RV afterload, increase the RV stroke volume, and induce the uncoupling. Whereas our PV loops, these are 4 of my patients, don't look anywhere as pretty as Bill's because they end up just all over the place. And these are 4 VAD patients we ranked up and down to understand the role of this interventricular dependability on each other. And bottom line is, I don't think we truly understand the systolic, let alone the diastolic interactions of a RV with the LV, especially in a VAD situation. They just behave quite differently than other ventricles do. So my key points again is learn to appreciate the role of BiV congestion in LV failure. Patients don't just focus on the LV, but also learn to understand and estimate the impact of the prognosis of RV dysfunction on these patients. Usually if the LV unloads and you talk to the RV nice enough, it responds, but you have to be patient, you have to give it time. Just decongesting it for a couple days may not be enough. And truly, we don't understand how much the temporary and durable MCS devices have the interplay on these biventricular contraction, but something, work from Bill, Stephen, and others will hopefully teach us in the years to come. Thank you.
Okay, we'll open this up to questions from the panel and from the group.
One basic question, your patient Dave, he has atrial fibrillation. Could it be a tachycardia-induced cardiomyopathy? And before we went for Impella, could we have treated atrial fibrillation? And
so certainly it was tachycardia cardiomyopathy. We think brought about by his, we never did his biopsy, so even though he presented like a myocarditis-like scenario, we think it was tachycardia cardiomyopathy. But at stage D shock with a lactate of 9, I did not think with those filling pressures we could have cardioverted him successfully. We did try, but it was, he would just not. We failed 3 times to cardiovert him till he became euvolemic, and then we were successful. So the etiology was tachycardia, cardiomyopathy most likely, which is why he got so much better so quickly.
I will also say sometimes you cardiovert these patients and they get worse because their underlying bradycardia is worse than the output they have with the AFib. So it is not an easy art of hemodynamic optimization in these patients.
Manreet, a lot of this is nuance in the details. So just out of curiosity, when you were on the Impella 5.5 and you look at the console, were you seeing LVAO uncoupling? Because usually we use that as an indicator that the RV is, there's either a fixed obstruction with the PVR, your PA systolic was still around 57 despite having the LV unloading, and that uncoupling is usually a harbinger of badness.
Yeah. I don't recall, to tell you the truth. I wish I could tell you we did do all that inside. I think we looked at the hemodynamics, felt comfortable, and went ahead, but we should have, but we didn't.
Yeah.
I don't remember.
Steve, to ask you a question, you brought up the fascinating concept of pericardial restraint. So, given the cases you've just heard and also your own experience, is the pericardium a target of therapy?
That's a great point. That's a great question. I don't know how we can target the pericardium to help, but I know it can certainly hurt. So with LVADs, there's probably some degree of RV harm that happens with a traditional full sternotomy LVAD as opposed to doing a lateral thoracotomy approach that's minimally invasive that spares the pericardium. So I know Ryan Tedford put out a nice paper showing that, and with kind of single beat PV loop assessments as well, that if you do the minimally invasive lateral and preserve the pericardium, you get less RV failure post-LVAD. And so maybe for these vulnerable RV, clearly this is a vulnerable RV that you guys ran into, like that showed a little bit of oomph, like in fight, like after the Impella, but could not get through the surgery. Maybe leaving the pericardial, like, with these sick RVs, like they almost need that cummerbund that the pericardium provides to like keep it together. And that might have helped, so.
Yeah, good to know. Maya?
Great cases, actually great series of cases demonstrating the effects of different therapies on right ventricular dysfunction in advanced heart failure. I would argue that the first case was not about right ventricular failure at all because no therapies were specifically targeting right ventricular function. It was a case of chronic heart failure with decreased cardiac output that makes all difference in the world. I would argue that this is a rather thick red line between heart failure and advanced heart failure. Once they cross this threshold, once low cardiac output kicks in, you cannot just get by with the diuretics regardless of the amount and guideline-directed medical therapy because they won't tolerate it at this point. You need to increase cardiac output by whatever means you can. If inotropes are sufficient, fine. If temporary support is sufficient, fine. If not, you move on to ultimate decisions like LVAD or transplant. Second point I wanted to make about Manreet's cases. We all know that in LVAD, there are 2 potential mechanisms of right ventricular dysfunction. First one, permanent LVAD violates, disturbs the geometry of the right ventricle because it changes the motion of the septum. Second, it increases the workload on the right ventricle. Impella 5.5 would do the same to the workload, but it would not distort the septum because there is no surgical intervention with permanent changes of the geometry of the heart. So maybe these 2 cases give us a clue that if we are afraid of right ventricular failure, it makes more sense to keep them longer on temporary support to fix these effects of low cardiac output without permanently changing the geometry of the ventricles. I think everybody knows this paper by Uriel. When you increase the speed of the LVAD, you bring down the end ventricular volume and diastolic volume of the left ventricle. At the same time, increase in end diastolic volume of the right ventricle. So perhaps dealing with temporary devices like Impeller 5 or 5.5, we can avoid this unnecessary disfiguring of the right ventricle and help preserve this function. This is just a hypothesis born from the presentation of these two cases.
That's great. Thanks for the comment, Maya. So we're gonna move on due to time, and thanks, Manreet, for a phenomenal talk. The next two presentations are going to talk about hemodynamics and decompensated heart failure and some of the emerging concepts for intervention. And so we're fortunate to have Jim Udelson coming to us as the Chief of Cardiology at Tufts Medical Center and in charge of the overall structure on which interventional heart failure program was built. So thanks, Jim, for joining us. And we look forward to your talk on intra-atrial shunts.
Thanks. The only credit I will take for that is hiring you, so that I take no other credit for that. So we're going to, in the next couple of minutes, switch chambers to the atria and switch interventions and talk about intra-atrial shunt and focus, just because we have a few minutes, on some of the interesting atrial hemodynamics. So I'm a consultant and I'm the PI for the pivotal trial for the Alleviant shunt approach. So this is a case that was done by Brian Potter up in Canada in one of the phase 2 Alleviant trial. The trial was called Alleviate HF2. Typical older HFpEF woman, comorbidities, prior ED visit, class 3, and really concerned about her autonomy and her ability to stay at home. And the hemodynamics here in the exercise right heart cath are what we would like to think are is the strike zone for this kind of therapy. Moderately elevated wedge pressure at rest, skyrockets during exercise, with a gradient between the wedge, left atrium, and the right atrium at all stages, suggesting that if you impose an atrial shunt, there will be left atrial to right atrial flow, decompressing the left atrium. So we'll loop back to this at the end. Here on your left is the Alleviant procedure. So there's a transeptal wire. This catheter is put across the atrial septum, and you can't see it too well, but a nose cone is advanced followed by some tines, then brought back into the housing, pulling a piece of the atrial septum inside the housing. Radio frequency energy is applied to cut a very clean little hole of tissue that you see on the bottom right, and then removed, and you end up with a no implant, about a 7 millimeter hole that endothelializes, at least in the preclinical models, and to date has been patent out to a year in all cases studied. You know, in the pivotal trial, we'll actually have 500 or 600 atrial plugs like that Stephen's colleague Kavita Sharma and a committee will be, along with David Cass, will be studying. We'll learn a lot about atrial tissue that I don't think we've ever known much about before. So I wanted to focus, just based on the assignment of the title that Navin gave me here, on sort of the atrial hemodynamics. And I never really thought too much about the atrial septum, but it's pretty dynamic, actually. It's not just this fibrous piece of tissue. And it suggests that it contributes, you know, just like Stephen was telling us about the shift in the ventricular septum can really affect biventricular hemodynamics. You know, it seems possible that the function of the atrial septum is actually really important in hemodynamics. So let's think about that in terms of the types of implants and the different approaches. So this is from a review article last year by Sanjeev Shah and colleagues. So several of the approaches to intra-atrial shunting involve an implant into the atrial septum, the Corvia device, the V-Wave device, and Oculotech. And the size of the shunt is all a little bit different. We don't really know if that's important or not. They all eventuate in left atrial to right atrial flow. And I'll update the development stage a little bit here with the V-Wave, as you know, was presented a couple months ago at the ACC. And Oculotech actually has been halted. Their pivotal trial, FROST-HF, has been halted for some reason. And we'll talk a little bit more about this at the end. On the right is interesting. The Edwards device approach is a left atrium to coronary sinus shunt. It is an implant to kind of hold the shunt open, but there's no effect on the atrial septum, which again might be important. And then there are several procedural approaches which do not leave any implant. And the furthest along is the Alleviant device, which takes out that core of tissue. It results in a 7mm shunt. There's a pivotal trial called HFrEF, which is now ongoing. And the other two that are shown here, Noya and Intershunt, are much earlier in the development, so not a lot of information there. So is this important to maintain sort of the function and the structure of the atrial septum? So on your left is kind of pre-shunt, and you can see the atrial septum there, pretty active. And again, perhaps that involves hemodynamics. On the right is post-shunt, with an Alleviant procedure. And as it flips by in diastole, you can see the little hole there that we don't have the Doppler flow. But besides the hole, the atrial septal function seems to be pretty maintained, if you look on the left. In the middle is one of the implant shunts, which, as you can see, somewhat stents the atrial septum. And again, is that important or not? We don't really know at this point, but there's preservation of septal motion with this no implant approach. Here are some hemodynamic data from the phase 2 Alleviant trials that were published last year in JACC heart failure. Exercise hemodynamics on exercise stage on the x-axis, pressure on the y-axis, and at each stage, this is an open label trial, uncontrolled, 28 patients, everyone got the shunt, baseline in dark, 1 month in lighter blue, and you can see there was about a 5-ish millimeter on average reduction in peak exercise hemodynamics. Now, there have been, over the last few years, several other studies that have been published with 1 month hemodynamics. This is the Edwards AltFlow early feasibility study published last year in JACC Intervention, average 7 millimeter reduction in exercise wedge pressure. Reduce LAP heart failure, published a couple years ago in Lancet, 2.5 millimeters reduction, and the Reduce LAP heart failure 1, published a few years ago in Circ by Ted Feldman, 3.5 millimeter reduction. But so they're all doing what they're supposed to do in a way, but I think what you see here is that the procedures that do not impact the atrial septum seem to have larger improvements in exercise wedge pressure than those that have a septal implant. How does that play out, or does it play out into any clinical effects? We don't know at this stage. Time will tell. These are some data that were put together they're not published, by Murat Fudim and his colleague at Duke, along with Miguel Lofer-Pearl in Israel. And these are the echo data from the Alleviate HF 1 and 2 trials. Left atrial pressure on your left with a reduction at 1 month after intraatrial shunting with no implant. LA maximum volume reduced at 1 month and 6 months, and the atrial work, I don't know how, I'm not an echocardiographer, don't know how that's done, but down is good, so there's less atrial work 1 month after the shunt than there is beforehand. So all favorable effects on different measures of left atrial structure and function following a no implant intraatrial shunt. And here are some early data on strain of the left atrium and the right atrium, showing, I won't go through the details, but improvement in atrial function with about a month after, 1 and 6 months after these shunts. So the increased reservoir strain on the bottom, and data not shown, no adverse impact on the right atria, suggest improved overall atrial function. How does this play out in terms of reduction in heart failure symptoms, KCCQ, heart failure hospitalizations? We will see over time. So if you look at the data that are available to this point, biatrial hemodynamics are the gateway to many of the intraatrial shunt trials. And one thing that has really been done with these trials, there's now several hundred sites that have participated in these trials that are doing exercise hemodynamics. So it has really sort of spread that gospel. Atrial hemodynamic response may, and that's the key word there, involve the impact on atrial septal dynamics. And it's very distinct between the different approaches. Whether this influences clinical endpoints remains to be seen as pivotal trials go on. And I think also these trials have opened in some ways a new window into the study of atrial hemodynamics, which is really, really interesting. So in the last, here's loop back to our case. Of course, I'm only showing this because she did really well. She had her intra-atrial shunt, went from class 3 to class 1, out grocery shopping, running around Montreal, whatever. So it can work. This is open label, not sham controlled, et cetera. But we've seen a good number of people like this in the early trials. So I wanted in the last moment, this whole area has been a real roller coaster, of pivotal trials and subgroups, and it's really confusing unless you're really, really into it and follow it really closely. So I wanted to try and summarize, what's going on at this moment. There have been 2 pivotal trials in this space presented or published. The Reduce LAP Heart Failure 2, published 2 years ago by Sanjeev Shah and colleagues, and the Relieve HF V-Wave data. The first one was Corvia, the Relieve HF V-Wave, which was presented by Greg Stone a couple months ago at the ACC, not published yet. And both trials were neutral, on their primary endpoints. But there was a lot of information in subgroups. So in Reduce LAP HF2, there was a responder group, separate paper by Barry Borlaug, exercise PVR less than 1.7 and no pacemaker. They did much better than the non-responder group, and they've continued to do better, followed out to 3 years. And so that is being followed by the Corvia folks in a trial called Responder HF to confirm that in that group of people. And then we are doing a trial called Allay HF with the Alleviant approach, virtually the exact same people. So this subgroup developed a hypothesis, generated hypothesis, and it's being prospectively tested in 2 distinct pivotal trials with different types of implant approaches, 1 implant, 1 no implant. With Relieve HF, as Greg presented, there was a HFpEF subgroup that did poorly. They did worse with the V-Wave shunt, and their HFrEF people did well. They had favorable effects on virtually everything except KCCQ that was measured. Now, we don't have time to go into details, but it really very much looks like the HFpEF Relieve HF group were very similar in demographics, baseline biomarkers, et cetera, RV, bad RVs, et cetera, to the non-responder group in Reduce LAP2. It was a sick HFpEF bunch of people. And so I think the community has kind of agreed this type of patient should not be studied further. And HFrEF, the HFrEF patients in Relieve did very well, and I guess I would say stay tuned. And we involved in the Alleviant trials are developing a protocol, and we are going to go ahead and study and try and confirm what the subgroup in Relieve HF showed. So we will see over time. So I think the entire space can be illustrated by this. We're trying to find the strike zone. Can you decompress the LA without overloading the LV and the pulmonary vasculature? If you're too early, you can't show any benefit because the patients will do too well. If you're too late, there's a vulnerable right ventricle, vulnerable pulmonary vasculature, or symptoms that go beyond left atrial pressure elevation by all the other comorbidities. So everybody in this field is trying to find that strike zone, and we will see over time, with the multiple pivotal trials that are ongoing. Thank you very much.
Jim, that was a great summary, and the last slide, always ending with stay tuned, is a great cliffhanger. One question I had for you is around, this is an interventional meeting, and there's a lot of transeptalists who are doing transeptal punctures for left atrial appendage occlusion, for MitraClip, for lots of therapies, and we never close the hole on the way out. So, and yet that hasn't really fallen out as a signal, especially in COAPT. There was a small study of closure of the intra-atrial septum on the way out and really showed no difference whether you closed or left the hole in place. So can you comment a little bit about that, especially for the interventionalists here who are living across the transeptal zone? How does that affect, your thinking around things like Allay HF?
Yeah, thanks so much for asking me an interventional question, Navin. I really appreciate that. So I assume I don't know, but I assume in those other procedures that it's actually a very small hole that has been created. Is that correct?
Yeah, so for example, with MitraClip, they're on the range of around 20. So they range between 18 to 22 French, let's say. Millimeters in the range of about 4 to 6
divide
millimeters.
by 3, as I recall, something like that. So, So they shrink over time. I remember that has been demonstrated. So here, I guess I would say they don't shrink. So we know, like in the Allevian approach, out to 12 months in all the phase 2 trials, everyone had either TE or CT. Everything was patent, size was exactly the same. And then, of course, the implants, almost by definition, the size was the same. So, in that sense, you have a stable shunt, over time. And in all of these studies, the FDA is mandating multi-year follow-up because you don't know. I mean, maybe over time, maybe in 2 or 3 years it's good, and in 5 years it's not so good. So that balance, will be important. But I presume if in the other procedures, if they are getting smaller, the impact would be hard to assess.
So I had a question. So I think, interventionalists are relatively straightforward and we like black and white solutions. So when this came out, it was like, oh, it seems like a no-brainer. You make a hole there and you decrease some of the, shunt some of the flow and maybe decrease some of the pressures. But is this more of a compliance problem rather than a volume and flow problem? In other words, have we not understood properly the LA as a chamber in between the lungs and the LV? And we all know these patients with severe MR, very dilated LAs, they oftentimes don't have V wave, they don't have, you do V waves in the tracing, and they may shield the lungs. So talk a little bit about the hole versus what the device is doing to the compliance. It might be that it's changing the size of the LA and offsetting something.
Absolutely, and I think, you start off thinking very simply, and, at first there was a lot of discussion about, the size of the shunt is bigger, better, small, the V wave is 5, this is 7, Oculotect was 8 or 10, but it turns out, that's only one little piece of the equation. It's the pressure, it's the compliance. This is really complex hemodynamics. And, there, I think what we'll learn, so the answer is I don't know, but we will learn, from these studies of atrial hemodynamics and reservoir strain, we will learn, are those things improving? And then, on your particular point, Ari, about the compliance, is it better to have no implant to maintain the compliance and keep pressures somewhat low, or does that matter if you kind of stent the atrial septum? We don't know that at the moment.
I think it'd be nice to do. We do tons of PFOs or, in patients who don't have resting flow. It'd be nice to see what happens to LA hemodynamics when you close these. We like to see, oftentimes we like having these devices that straighten out the septum, but we don't really know. And since these are young patients with no heart failure, oftentimes we don't know that there's incremental damage to that, but it'd be nice to see that.
I think those are great comments, so do we have a question? Oh, sorry, there's a blinding light behind you, Carlos, so I'm sorry. Go ahead.
So from the clinical trial perspective and design and a post-orbital era shunt control trials, and most of these devices being based on patient-reported outcomes, how do you see these trials being designed in the future for not the pivotal, for the large trials?
Well, the pivotal trials have all been sham controlled. And, when it is, and for device trials, a lot of effort is made to blind the patient, blind the initial team. There's going forward, there's a blinded team doing all the assessments because, as you suggest, some of the endpoints involve KCCQ and a win ratio, and, there was a lot of criticism in the tricuspid trials about that. Is that real or not? So, I think every one of the pivotal trials has been as rigorously designed as you can for a device trial so as to allow incorporation of KCCQ. But it's a really important design feature.
Thank you so much for your time, Dr. Udelson. I would like to invite our next speaker, Dr. Arvind Bhimiraj, who's going to continue to shift gears a little bit and talk about preload reduction in HFrEF management.
Thank you. And I want to thank CVI's organizers and Navin for this kind invitation. And really, I'm impressed by the attendance here so we can heart failurize the world, especially the interventional world. You have heard a lot of pearls of wisdom about hemodynamics, and really I would urge that each of those pointers that all of our speakers gave are really not what are included in the textbooks, so please remember some of those caveats for patient care. I will be discussing non-FDA approved devices, especially precardia as a concept for preload reduction. Then we'll jump right into setting the stage, and I'll try to point out some of the clinical relevance of it. So this was a 45-year-old gentleman who was undergoing an advanced heart failure evaluation with a long history of heart failure for about 20 years, had an evaluation 10 years ago, stabilized, but then, of course, now started deteriorating. You'll notice that he's on good doses of medications. Along with that, he was on torsemide of 80 BID, was still NYHA class 3 symptoms. And I want to point out that when you look at this patient being admitted from the Cath lab because of abnormal hemodynamics, that's a profile which is decompensated heart failure, contrary to what we classically look at people coming into the ER or extremely short of breath. So remember that this heart failure world has evolved where we're respecting abnormal hemodynamics as a decompensated heart failure, not just people feeling bad. So this is the echocardiogram that you see. The heart's barely moving. Let me go back and show you. The EF is very low, which I'm sure everybody will agree. Of note, not enough mitral regurgitation to chase it, which has become a check-off list for us to do along with GDMT medications. So he gets admitted for this hemodynamics. You notice that the RA pressure is 20, PA pressure 74/48, wedge of 36, cardiac index 2, other hemodynamics relevant. The TPG is high, so transplant's going to be a problem for him. SVR is high. There is some room for adjustments, but you've noticed that he's on max medications already. Laying flat in the table, walking around, does not disqualify people to be in decompensation. This guy is walking around, came, laid flat, no discomfort, but a wedge of 36. So please remember that part. He was put on a Lasix drip, and then we'll talk, I'll set the stage for what precardia and venous HF trial is, but we screened him for the trial, and the trial requires that you have to show that diuretics are not working. So he was on diuretics, he got screened, and essentially with 48 hours of diuretics, his RA pressure did come down, somewhere between 12 and 16. PA pressures are still high, wedge got better, but still not ideal. Of course, index is low, MAP is high, SVR is high, TPG is still high. So worked, but not perfect. Right? And so let's take a step back and talk about why this is important, why this case scenario is important. How many of you here, show me your hand, raise your hands, when you're treating patients with heart failure and you have hemodynamics, you think about afterload as a concept. Blood pressure, I want to reduce afterload. How many of you have typically thought about preload as a concept? Good. I didn't raise my hand because it's not an incorporated thing in our learning. And the reason why I put up this slide as neglected concepts in heart failure is for the last 10 years, we've now called the RV as a neglected child, and we've learned about RV, we're talking about RV, which didn't happen in the past. Now we're realizing that we don't know what the autonomic system does, and preload is one of the concepts that I believe is being opened up by these interventions. When we think about preload, you think about physiology and the sarcomeres opening and closing. That's the first thing that comes to our head. But that is a cellular level preload, which is less relevant at bedside. But what's more relevant is the organ level preload and this conceptual framework of preload as the beginning point of the chamber. You have preload of the RV, you have preload of the LV, we have preloads of the RA and LA, which we have not still explored. So it's the aspect that what is the beginning point, volume, pressure, all those are interchanged. So there's a bunch of confusion around this concept, because when we say preload, we think about volume, but we use pressure as a surrogate marker. It does reflect some amount of preload. So it gets confusing, so that there's more and more that we need to invest in understanding the impact of preload in this particular setting. So when you think of preload on the pressure volume loops that you see up here, as you change the beginning point, you notice that the blood pressure changes. You can impact all performance or load dependent factors of the heart without changing contractility. You're not inotroping the heart. That line didn't change, so you know, let me go back. So this line didn't change, so you're not changing the contractility of the properties, but you're changing a lot of other parameters. So preload becomes important. So what affects the preload? Of course, the heart tissue, dilation, TR, RV is too big, you have regurgitation. For the right side, same thing for the left side, that's preload for it. Blood volume, total volume. And there were some key points that were made about weight, no change of weight, no change of pressures, which is important to understand because when you talk about blood volume, the volume can be hidden and just redistribute in your body. And that's what I will allude to you, that there's so much splanchnic circulation that can move into the heart without changing the weight of the patient. So the volume status, overall, the total blood volume impacts it, but then you have to translate that into volume of the chamber that you are thinking about. And of course, what controls the volume? The vasculature does control the volume. We have thought a lot about afterload. I mean, 10 years ago in my fellowship, we would beat that SVR to death in my fellowship, calculate all these nitrites, but I don't remember talking much about preload at all. So that's why I think we've accepted afterload with afterload reduction, afterload reducing agents, but we don't talk about preload reduction, preload reducing agents as much. So I will embark upon you that 70% of the total blood volume is in the venous system. So when your vessels clamp, your arteries are clamping, but the veins are not isolated. So when your veins clamp, you're talking about 70% of the blood volume being mobilized, and that's a significant amount of total body volume becoming the preload for the heart, and that preload system needs to be acknowledged. And interestingly, some of these things were described a long time ago, that the RA-SVC junction has a bunch of receptors which, based on the preload adjustments, can impact your urine output. We think about neurohormonal axis. We don't think about a hemodynamic axis. More importantly, we don't think about a hemodynamic neurohormonal axis, but we know that. Atria stretch, ventricles stretch. So when they stretch, you increase the natriuretic peptides. So that's the pressure volume translation into neurohormonal systems. So what do we do about preload? There's a bunch of investment that has happened, and this review by Manreet shows really beautifully on some of the pharmacological impacts on this, but also some of the interventional investments that have started really opening up this field. About splanchnic nerve modulation is one therapy. Today we'll try to focus on some of the vena cava changes that contribute to this preload axis as such. There are two passive mechanical preload reduction systems, which I'm not going to go into because the case today is about the precardia system, but these two are under investigations at this stage, probably a little further behind the precardia study in the realm of clinical trial. So what is the precardia system now that we set the stage that preload is important? Precardia is a smart device or a catheter system that has essentially like a Swan-Ganz, pretty much it's a balloon-tipped catheter, and you have an external balloon which is inflates and deflates, which has a separate port, and the rest of these are PA port, RA port, exactly. So pretty much it is essentially like a Swan-Ganz catheter placed in the position like a Swan-Ganz catheter, but this balloon is positioned at the SVC-RA junction. And it gets filled with an external pump control system, which is inflating this balloon and deflating the balloon, causing a cyclical mechanical stimulation, stretch, preload occlusion, whichever you want. I think there's more than what we believe this does. I mean, Navin's the expert in this, and he can correct me. I think the initial concept was the preload reduction, but it might be doing more than just the preload reduction in this situation. And as I mentioned, it's an investigational device. So this patient was enrolled into the clinical trial, and then you notice up here that it's a venogram for the SVC. You mark the positions. You put in the catheter just like a Swan-Ganz, and then you position it at the RA-SVC junction. The balloon gets inflated with half and half saline, so you can see that it is occluding the SVC, and then the contrast injection proximally confirms that it is occluded. and the machine outside will have a screen that will give you the pressure proximal and distal to the balloon, so you create a gradient across that. Typically about 5 in the initial trial, we do up to 10 millimeters mercury of gradient. And then it essentially cycles, inflates, keeps inflated for about 10 minutes, if I remember right, and then you deflate for a few seconds and continues to inflate. In this trial, in this patient, essentially, this is this patient, you'll notice that this is the initial urinary output response that this patient had with the Lasix drip of 7.5 milligram per hour, but then you see that it plateaus out. And as mentioned earlier, we see these patients getting diuretics, but there is a resistance that plateaus. Now, is this making a difference or not? Again, it's the trial, I don't know. We're biased because we're not blinded. In this patient, he got the precardia device up here. The urine output it was only 24-hour placement because it's a early feasibility study. And for 24 hours, the urine output didn't change much. The diuretics did not change per protocol. And then the precardia device was taken out. But interestingly, without any change in diuretics in this individual, these are the urine outputs that continue to increase. I think this is an older version of my slides. Looks like they've uploaded. But these were hemodynamics at the end of the visit. But prior to this, the hemodynamics up here showed that the RA pressure was about the same. PA pressures were still in the 60s. They got a little better, but not completely normalized. And of course, we did some Revasio, increased diuretic here to 10 milligram per hour for a day. And then the patient went home with these hemodynamics. I was actually very impressed. Even though he was on Vercubo as an outpatient, I couldn't get his PA pressures down. Is this the precardia or not, or is it, I don't know. But I was happy that his TPG got better to a point that we actually listed the patient, his outpatient now, with the cardiomems, and then we'll see what happens to him. So in summary, the decompensated heart failure therapies, and I should learn from the recent review that Navin put together not to call it acute decompensated heart failure. It is decompensated heart failure, because by saying acute, I'm contradicting myself that you don't have to be in the ER. It's decompensated heart failure. When somebody is decompensated, we don't do a good job in getting them to optimalemia. And we know those statistics. When patients get admitted for heart failure, close to 40 to 60% of the patients are not dry enough when they go home. So they go home still congested. So we don't know how to do that. Diuretics have been the cornerstone, but we know they don't work as well, and they got a lot of harmful effects. Various devices are in the pipeline impacting this area of preload. But more than the device, I think what is fascinating to me as a heart failure hemodynamic guy, that it's opened up this world of splanchnic reserve and autonomic nervous system impact, and this whole concept of hemodynamic neurohormonal interaction that hopefully can be exploited into mechanical preload reducers to impact acute decompensated or decompensated heart failure, because we have not made a dent in outcomes of patients who get discharged from the hospital. None of the GDMTs per se have been shown, so we need to do better, and hopefully this will help in the future. Thank you.
Perfect. Thanks, Arvind. So just for time, we're going to move on to our next talk, but thanks, Arvind. Really terrific presentation on cardiac preload. Our next speaker is Imran Aslam, who's coming to us by way of Johns Hopkins, so another person from the Dome, who now is at Duke. Imran is also interventional heart failure trained and is a translational hemodynamicist. So, Imran?
Thanks, Navin. So as Navin said, I'm interventional in heart failure at Duke. I think, thank you everyone for inviting me and CVI and Navin. I think I just have to say, I think you don't understand how important our conversation was years ago when I was a first-year fellow at Hopkins and trying to make a decision between interventional and heart failure and thinking I was crazy. And then once we talked, felt more confident in making this decision to do both. With that being said, I'll get into my talk knowing that I was going to be the standing between everyone and lunch. I'll make this short. And focus on the case and hopefully some good discussion points talking about preload and afterload in a patient who was in cardiogenic shock and ended up going on VA-ECMO. no relevant disclosures. So this patient was a 49-year-old female, presented to a local hospital, not to our hospital initially, with confusion, diaphoresis, some emesis, and some vague abdominal discomfort. She was brought to the ED there, where she ended up having, unfortunately, a PA arrest, had CPR for about 20 minutes, eventually getting ROSC, got intubated, and was emergently transferred to Duke University. There was a concern on her EKG for ischemia, which we'll review here in a second. But she had no prior medical history, so kind of coming to us as a blank slate. And this was her presenting EKG. You can see here, obviously, there's some concern for anterior ST elevations, kind of diffusely throughout your precordial leads, a little subtle in the lateral leads, but enough in this situation to obviously take the patient to the Cath lab and to take a look at what we see here. And so this next slide, you can see these videos playing the RCA here. Looks like a kind of severe lesions, obviously, throughout your RCA, concern for kind of distal CTO there with some collaterals, as you can see to your left, to your LAD system. And this is your LAD system, a little subselective in the circle there, but you can see, obviously, there's poor flow in the LAD. If you look carefully, may not show up as well here, but there looks to be some filling defects in the mid-LAD, concern for thrombus and to be the acute lesion. At that point, the patient was obviously hemodynamically unstable and started to go on some norepinephrine. The operator who was taking care of the patient was concerned that, given the patient's size, that they wouldn't accommodate large bore access, so a balloon pump was placed and the intervention to the LAD was undertaken. It was pretty straightforward intervention. You can see here they put in a big stent, used intravascular imaging, confirmed appropriate apposition, et cetera, and they got a great result. But looking at the post-PCI hemodynamics and obviously the clinical picture, obviously you want to be, as Navin says, an operator for, doctor first and operator second. But looking at your big picture here, patient's hypoxic on 14 and PEEP, obviously on some vasopressors, but also some sedation. You can see here the R rate at that time is 13, your PA pressure 35 over 22, kind of a low pulse pressure there, obviously. Not terribly elevated filling pressures, but not a great pulse pressure there. Wedge is 15, index is 1.9. This is with 0.1 of levo and a balloon pump, CPO and PAPI there, as mentioned. So again, at that time, there's a concern that any escalation would not be accommodated given the patient's vasculature. And the clinical challenge here is a post-CICU course. The patient comes to the CICU, their lactate was 3.8, started to rise. LFTs are obviously elevated, as you can see here, 1,000 for the AST and then the hundreds for the ALT. And elevated glucose, so obviously concerned that this patient had diabetes, was obviously in a hyperglycemic state, very terrible urine output, ice cold bilateral extremities or on exam. Hemodynamics you can see here, so the blood pressure by art line 99/62, MAP of 70. Hemodynamics there, again, filling pressure is not terrible, right, with regards to the actual absolute number, but a very poor PA pulse pressure. Wedge pressure of 20, index was pretty abysmal, and escalating on your vasopressor requirements there. At that time, there, again, given the concern for being able to accommodate escalation, there's some attempt at using some inotropes by the CCU team. Didn't really go well. There's an increase in ectopy and some ventricular arrhythmias. So at this point, we have continued escalation of vasopressors, lactates going up, poor urine output, hemodynamic criteria for shock, and the concern at this point, obviously, is you not only have the initial insult to the LV causing LV failure, but you've got biventricular failure. Thinking about the angiogram, you had an RCA, which was ischemic, getting likely some collaterals from the LAD that went down, and now you're dealing with some RV dysfunction as well in this situation likely. And so the question became, what do you do? Clearly medical therapy is not working for this young patient. How are you going to escalate? Are you going to go to Impella CP? Is that going to be sufficient? You've got some biventricular dysfunction, so should you think about bipella support in these patients? Should you think about an ECMO situation with the balloon pump in place? Which way should you go? Again, consideration for vascular complications in this patient who's 5'4" and a BMI of 25, so not a very large patient. So I think this is kind of highlighting a very difficult patient population where you're concerned about vasculature, you're concerned about clearly the hemodynamics being very poor forward flow, but not very high filling pressures. Modulating your preload and all that stuff that we just talked about may not necessarily be in play here. Some people say, okay, well, this patient also has RV failure. Why don't you try a little bit of inotrope, give them some fluid, see if you can get them through this, which was tried clearly, but did not go well. And so I think our plan, and I think you can go different ways with this, obviously, and we can discuss this, but the plan was, well, let's place a CP, and because with a tentative plan to escalate to ECMO, I think the concern by our team as we had convened our shock team was maybe Biatrial support would not be enough for this patient. Also, the patient was hypoxic. We're concerned about lung injury and being able to oxygenate the patient. And so our tentative or our backup plan was ECMO. I think got involved with this patient at this point, and I think people were more comfortable with large bore access. We decided I think this patient would be able to take a 14 French to the leg, and if we needed to do a distal perfusion catheter, we'd be able to do that. And so we ended up placing the Impella CP. But you can see here with the hemodynamics after the CP gets placed, not that much better. Yeah, the wedge is a little bit lower. Index is maybe a little bit better. We were on a little bit less pressor, but again, still pretty abysmal output. And our urine output had no improvement. And this is all within the first 12 hours of the patient presenting to our hospital. Lactate's still 3, urine output with no improvement. So at this point, we decided to take the patient to the cath lab. And this is just to give you a sense of what the TTE looks like before the Impella went in. Very, edematous looking, thick LV, not dilated, small. We don't see the RV very well here, and we had some limitations on obviously getting pictures of the RV, but the RV wasn't very dilated as far as we can tell. Again, very small heart, small chambers. It's not like we're dealing with very high filling pressures in a very large chambers. So ended up escalating the patient to ECMO, and basically prophylactically put in distal perfusion catheters for both legs because the concern was for the leg with Impella that we're not getting enough flow to that leg, and to avoid ischemic limb, ended up wiring that into the ECMO circuit and put the patient on ECMO. And put a 15 French in, again, given the concern for being able to tolerate a 17. That's our typical, is to go 17, but in this patient we went 15, put in a 25 venous, and like I said, DPCs for both legs. So the patient, after that, ECMO flows around 3 liters per minute. If we tried to go higher, we started getting suction, chattering on the circuit. Our Impella CP was about P2, P4. Lactate started normalizing pretty quickly. LFTs over the next 12 hours started downtrending. Very, very quickly after that, the urine output within the next 4 hours started going up. Creatinine, obviously, over the next 12, 24 hours got better. Completely came off norepinephrine. Obviously, within hours of going on ECMO, MAPs were pretty high. Blood pressures were improving. These are hemodynamics on ECMO for what they're worth. Obviously, even lower filling pressures, not surprising. Impella suction alarms were starting to become an issue. So this is where we started giving fluid boluses to help modulate that preload, so we could get, have no suction alarms and not run to hemolysis, et cetera, with Impella. 48 to 72 hours, the patients, as mentioned, the pulsatility was improving. Very minimal to no support on the Impella. Did a bedside ECMO wean and tried to see whether or not we'd be able to maintain appropriate hemodynamics with minimal to no support on the Impella. And I think at that point we saw that, again, the filling pressures that I show here didn't really change that much on the wean, indicating that perhaps we're having some recovery here. And so we took the patient and went ahead and decannulated as we were coming off ECMO, and we ended up starting the patient on some milrinone. With decannulation, the Impella was removed simultaneously because, again, we thought that the patient would not need that level of support given our wean that we tried at bedside. So you can see here that within the next 24 hours, we were able to wean the milrinone completely off. You can see an echo here of the patient's LV. Now we're getting a good look at the RV as well. Much better function than before. Hemodynamics, you can see here, much better, indicating recovery. Obviously, the patient had, not surprisingly, uncontrolled diabetes, hyperlipidemia, tolerated GDMT initiation over the next week, and discharged. EF clearly improved over 35 to 40%. This is a case from a couple months ago, so the patient's been followed up in clinic, doing much better and tolerating GDMT. So I think takeaways from this case, very challenging case with biventricular dysfunction post-MI, lower filling pressures. We're not dealing with very high filling pressures, talking about where we could modulate preload, perhaps, whether it's diuresis or otherwise. And I think in these situations, be prepared to manage biventricular dysfunction, even though your initial insult is, to the LV. Obviously, it was a pretty large anterior MI in this patient, but this was a patient who had an RCA-CTO, likely living off some collaterals from the LAD, which took a hit. And so instead of focusing, on just the initial insult to the LV, we started to clearly realize that PA pulse pressure, though the PA pressures weren't very high, the RV wasn't dilated and dysfunctional by echo. The optics, and we were creatures of optics to some degree, so looking at that was not the case, but the PA pulse pressure, and I think the lack of response to LV escalating support was really the key here. And I think it's up to a dealer's choice and arguments as to how every institution prefers to manage these patients. But in this case, we went with ECPella versus a bipella support option for this patient, and then balancing obviously the kind of discussions that we had earlier today about how we unload a patient with ECMO, whether full support with unloading with 4 liters per minute is truly unloading the patient versus doing an Impella, especially after a patient who just had an anterior MI and you're thinking, hey, maybe we should rest the LV so that we can have recovery when we're turning up ECMO flow so high. So I think that's something that's still obviously open to debate and controversial. And did RV decompression here help facilitate myocardial recovery in this situation is always a question. So I think again, very challenging case dealing with filling pressures that are low, biventricular dysfunction, and multiple different mechanisms of trying to figure out which mechanical support devices will help in these situations with regards to ECMO, ECPella versus bipella device when medical therapy is clearly failing in these situations. So with that, I'll conclude and open up for discussions or questions for this case.
Terrific. Thanks, Imran. That's a great case. I'll just start by asking, so on the heels of danger, this is a really nice case that illustrates perhaps some of the equipoise, and depending on the eye of the beholder, maybe the lack that there is no more equipoise. So does anything change in the Duke algorithm on the other side of danger as opposed to balloon pump first and escalating over a period of 24 hours versus direct to Impella and then ECMO if needed?
Yeah, no, I think great question. So I think I didn't do the first case. I ended up putting the Impella in and putting the patient on ECMO. But I think the concern by the initial operator, who obviously this was before danger came out, but we were obviously talking about putting an Impella in these patients when they're under supported because the balloon pump, as we all know, for these post-MI patients is frequently not enough. I think here it probably should have went in initially. I think the concern, which is completely reasonable, is in the heat of the moment, thinking whether or not you're going to cause more problems and not when a patient may not accommodate the vasculature. I think Sandeep obviously had a great case where he was talking about that. In that case, I think it was very obvious that they wouldn't, and I think you'd definitely run into vascular complications, which would be prohibitive. In this case, it's kind of on the borderline. I think you just need, as you know better than I, operators are comfortable making that decision on, okay, are we going to be able to accommodate that large bore device? Are we on that borderline here? And then choosing, instead of your standard 17 French, if that's what you go for ECMO, de-escalating, say, just put a 15 French in, go up front with DPCs, all this stuff to help avoid those ischemic limb populations. So I think the answer is yes. Our algorithm for these patients, I think, is definitely changing. It's just about the comfort in the operator in managing the vascular complications and prophylactically, for the ischemic limb complications I think that's where the comfort comes in, because putting an Impella in is not that hard, but it's all the stuff that happens afterwards that I think people who become disenchanted with Impella is because of that, right? There's like, oh, it hemolyzes all the time, or oh, there's vascular complications. Well, if you can be proactive and manage those, then you don't run into those as much. So I think that's something else that isn't talked about as much, right, with regards to, okay, MCS with an Impella up front. So.
I think this case illustrates how, in the first talk we heard about how underutilized PAC is, but we don't talk about how underutilized the information we get from the PAC is, how little we understand the hemodynamics in a lot of the cases. Here we talk about not very high filling pressures, but the patient's completely vasoplegic, post-cardiac arrest. That plays a big role in the filling pressures. And it plays a big role in the interaction between LV and RV. For a patient who was living at home, had a LAD infarct, a wedge pressure of 20 is probably very high in this circumstance of vasoplegia. We use, a lot of inter-atrial septum shunt creation in VA-ECMO to unload the LV, which I think we would have used in this case. We use it a lot in patients who have cardiac standstill or very low left ventricular function after arrest, for example, in VA-ECMO. And we see that not only the LV filling pressures come down, but the CVP comes way down. It doesn't go up, it goes way down. And I think that illustrates the question about whether the pericardium is a target. Here we're not treating the pericardium directly, but we're getting rid of the interventricular dependence to a big degree by creating this big shunt. We use like 18, 20 millimeter balloons to basically create a non-pressure restrictive ASD in these patients. And we really see a nice equalization and then rapid decrease in biventricular filling pressures without the expense of another MCS device like in this patient. And maybe the early research that you're doing, Bill, needs to be also focused on how do we integrate your PV loops into the daily PAC hemodynamics, and how can we create novel hemodynamic markers that we can get quick and dirty at the bedside in these scenarios to make decisions.
Yeah, the presence of dyskinetic septum, if you have done an echo before, would have helped you make a decision whether to go Impella or the ECMO. Because if there was a dyskinetic septum, you could expect with Impella it will improve. But with just a biventricular dysfunction, Impella alone was not expected to improve the condition.
Yeah, I think it's a good point. In this case, I think, and you could have made an argument that once the balloon pump went in and it was clearly not enough, that you could have just escalated to ECMO at that point rather than go to the Impella, because we had our hemodynamics indicating that we were in biventricular dysfunction, and escalating our LV support, whether that's an Impella or not, would not have been sufficient anyhow. So I think you could have made an argument to go ECMO up front right there, which I think was very reasonable. I think, again, the reticence was just putting in more stuff in a patient, right? Putting in ECMO, et cetera, when you could have tried, if you could have gotten away with an Impella CP, maybe that would have been enough. So I think this is just, comfort of the institution, comfort of the operator in this situation. But I think in retrospect, that would have also been very reasonable to do.
Nico, last question.
Yeah, so I was going to say pretty much something similar. Like we're running so often to this problem with these small ventricles after an MI. You cannot run the Impella more than P2, P3. It can, interfere with the pap muscle, can hemolyze. So, yeah, my comment would be, find another venting way, keep the balloon pump in, maybe escalate to ECMO, instead of going like progressively. That was kind of an alternative approach. Of course, people say, oh, why don't I try first before I do that? And I don't know what other people's thoughts about other devices, like use like a fair amount of like tandem hearts. Would that be another approach for, you unload at the same time? And of course it needs like an extra skill to do the transeptal puncture and everything, so it's not available to everybody. But I think we have a very good experience in my institution with the tandem heart so far.
Yeah, no, that's why I picked this case, because you could do multiple different things for this patient and potentially be successful. And then, it's one of those situations, you're damned if you do, damned if you don't. You don't want to wear, they go, why did you do that? If we went to ECMO up front, had a vascular complication, why didn't you try the CP first? Or if you did a tandem and you had a complication there, why did you do, shrug. You do what you can, but all great points, all great points.
Raj, we're going to give you the final word. Apparently nobody wants to have lunch, but they definitely want to hear what you have to say.
Thanks, Navin. It's Raj Patel with Oshner Health. Thanks for a great presentation, very interesting discussion. I just want to make the point that, Navin, the Cardiogenic Shock Working Group, and others around the country are generating data. We're figuring out what's going on with these complex shock patients, but one thing that needs to be taken out of the discussion is the comfort of the operator. We can't be making decisions for these patients based on the comfort of the operator, right? It's the onus on those of us who work in this space to build cardiogenic shock teams so that the comfort of the operator is not involved in the care of the patient. This should be about the patient's hemodynamics, the patient's pathology, and arguably the resources available at the institution, but not the comfort of the operators. We need to take that off the table if we're going to move the field forward. Thanks.
I'll just make a comment. I agree with that. I think it's sometimes easier said than done, but I think it just involves having people around that can help increase that comfort. It's just, it takes time, but I agree, yeah.
All right, well, that's a great way to conclude the morning and open up the afternoon talk session. So thanks, everybody. Thanks to the speakers.